I'm Dr. Tracy Papa. I'm a maternal fetal medicine physician, but I may not be your physician. So if you're not coming to see me in the office, remember, I'm not your doctor, and nothing on this site should be construed as medical advice. You always want to check with your doctor or your provider for any questions you have about your pregnancy. Hi, it's Dr. Tracy Papa. Welcome to the channel. If you're new here, I'm really excited to see you, and I want this to be a place where you can ask questions about your pregnancy. Whether you're high risk or high maintenance or a mixture of both, this is the place where you're going to get a lot of useful information and support for your pregnancy. If you like what you're seeing, don't forget to subscribe to the channel and turn on your notifications so that you can be the first to know when something new comes out. Today we're back with Sarah, who's a type 1 diabetic. Last week we covered the first part of pregnancy with type 1 diabetes. Today is part 2, and there was so much to cover that there will be a part 3 next week. We're going to pick up where we left off in the last episode. We're talking about our imaginary or composite patient, Sarah. She is 23 years old. She was diagnosed with diabetes when she was 8 years old, and she's been on insulin off and on this entire time until she became pregnant. In our first visit with Sarah and throughout the first trimester and up till about 20 weeks, which is the midpoint of pregnancy, we have worked on getting her glucoses under better control. We've counseled her that her insulin requirement is going to double or triple or even more during the course of the pregnancy, because that's what happens in pregnancy. She has gotten a normal EKG. We have collected her baseline 24-hour urine sample, and we have that number so we know where we're starting in terms of kidney function. She had an A1C of 10%. That's pretty high, especially in pregnancy, which means that she's got some work to do to get her glucoses under good control. Now we're at about 20 weeks of her pregnancy, and she's feeling pretty good. It took her more than a month to really get the hang of keeping her glucoses under control, eating regular meals, taking insulin on a regular schedule. She was on long-acting insulin and regular insulin. We've made some adjustments because there are all kinds of new insulins and insulin analogs out now. So we have put her on NPH, which is a intermediate acting insulin. She's on that in the morning and at bedtime. Now we're giving her short-acting insulin to take with her meals, and she's got a little bit of flexibility with that, and she's become very good at carbohydrate counting. It's really important to carbohydrate count, and if you get really good at it, then that makes it easier for you to be successful taking care of your diabetes, because you know that you're going to take a unit of insulin for every 4 grams or every 10 grams of carbohydrates. And if you can do that, that gives you a little more latitude in what you're eating, so that if you know you want to eat potatoes, for instance, with a meal that's a little bit more carb heavy, you can add a unit or 2 of extra short-acting insulin, and then when you check your glucose after your meal, it's more likely to be normal. So here she is at 20 weeks of pregnancy. We've been seeing her in the office every month, but she's been contacting us every week with her glucoses. This is really important, especially if you don't want to just live in our office. It's important for us to look at glucoses not every month, but every week, and sometimes even every few days if we're working hard to get your glucoses from up here to down here. She's having her next ultrasound. We've been doing these every month and watching the growth of the baby, but babies have to be usually about 18 to 20 or 22 weeks along before we can get a really good look at their anatomy. So we're going to look really closely at Sarah's baby. She's having a boy. And so he's wiggling all around. She is just starting to feel a little bit of that fetal movement. And we're doing a very thorough ultrasound called a detailed or a targeted fetal ultrasound. And we're going to look at all the parts of the brain, all the bones in the body, all the fingers and toes, as much as we can see of the heart, spine, kidneys, bladder, everything about the baby. In another 4 weeks, we're going to do our fetal echo. So this is a special look at the baby's heart. Remember that her A1C in early pregnancy was 10%. That's pretty high for those of you who are rookies who are wondering about this. Her second trimester A1C is now about, we're going to say 7%, and that's much, much better. She has done a really good job of bringing that down and getting her glucoses better controlled. So at our 24-week fetal echo, we're going to look again at fetal growth, but we're going to pay really close attention to the baby's heart. If we see a problem, a hole in the heart, a heart valve problem, one side's bigger than the other, or the plumbing isn't hooked up how it's supposed to be, if we suspect a heart abnormality, we send you to see the pediatric cardiologist. And if they confirm an abnormality, they will sit down with you and they'll talk about what the abnormality is and how this is going to be managed during the pregnancy and in the days following delivery. In Sarah's case, the baby's heart looks A-okay. We don't see any problems. That's a tremendous relief. So we go on through the pregnancy. We're seeing her every 4 weeks for an ultrasound and a check-in. She's sending us her glucoses every week, and we're slowly going up on her insulin because you become more insulin resistant in pregnancy, so you just require more insulin to keep your glucoses in the normal range. Between 28 and 32 weeks in the early third trimester, then we kind of step it up again. Instead of seeing Sarah every month, now we're seeing her 2 times every single week. Thanks for watching. I hope you enjoyed that and that answered some of your questions. Stay tuned for part 3 next week when Sarah has her baby. I hope you're enjoying Sarah's story. There's more to come in part 3, so stay tuned. Remember back last fall when I had a diabetes course ready to launch? Then I got COVID and all those plans got derailed and delayed for a little while. That course still exists and I'm launching it next week. Attached is the introduction to the course to give you more information about what's included. Check it out because I think you'll like it, especially if you have questions about how to manage your gestational diabetes. The cart stays open for a limited period of time, so the first few people to sign up are going to get all of this information at a greatly reduced price. Welcome. I am Dr. Tracy Papa, and this is a course about how to manage your diabetes in pregnancy. I'm a high-risk OB specialist, so I see diabetic patients every single day. Pregnant women who become diabetic and diabetic women who become pregnant. The process is pretty much the same, and the advice is going to look very much the same. When you get diagnosed with diabetes, it can be very confusing. You're overwhelmed and inundated with a lot of information, and there doesn't seem to be any agreement on how to eat for diabetes, whether you're pregnant or not. Some diets have more or less calories, higher or lower fat, more or less carbohydrates. What we're going to do in this course is put it all together for you and give you the training that you need to become confident about how to prepare meals for yourself and your family that are going to work for you. It's going to be tailored to your taste and interest so that you don't have to eat something that you know you're just not going to like. The course is a 4-week course. It's a 30-day course, and the transformation starts on day 1, so you don't have to wait till 30 days to see some big reveal. I love before and after pictures as much as the next person, but I also want something that I know is going to work starting on day 1, and that's what you're going to get right here. So the preparation day is the first day. That's where we're going to talk about what you need to get rid of from your pantry and what you need to stock it with, and how to grocery shop and how to plan your meals. Weeks 1, 2, 3, and 4 are going to build on the previous weeks. So you're going to learn some great habits. You're going to stumble and fall and fail. You're going to figure out a few foods that work great for you, and you're going to discover some foods that you might need to reduce or avoid because they're just not working for you. The last day, day 30, is your launching day when you're going to know with confidence how to shop for groceries, how to prepare a week's worth of meals with no problems at all, how to eat out at a restaurant so that you can be with your friends and feel like you're not deprived or sitting in a corner, but how to go forward and know that you're going to manage this okay. Not to be a downer, but diabetes in pregnancy is a very strong predictor of diabetes in life in general. About 60 to 70% of women who have diabetes in pregnancy are either going to stay diabetic or become diabetic. The good news here is that you've got some control over this. If you learn the good habits, if you learn how to eat well, if you learn how to move your body, you can affect that risk a lot. So this course is for serious people. It's going to be fun. We're going to have fun. We're going to laugh together, but you have to be serious about this, and you can't plan to cheat. You also can't be too hard on yourself. There are going to be failures, just inevitable failures. We all do. Even if you're eating the right things, sometimes things are not going to work for you, and it can be really frustrating to see a high glucose when you did everything right. We're going to learn how to troubleshoot. You're going to make some improvements, and you're going to be really proud of yourself when it's all over. So let's jump in.